Hello and welcome to MK's Exam Secrets. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at exam questions in one clinical course. Today in this episode, Season 1, Episode 8, we're going to be focusing on obstetrics and gynecology. So if you haven't yet subscribed, please subscribe to the channel, drop a like, drop a comment, and share the page. Hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. So beginning with our question 1, a woman admitted in the outpatient department complaining of having a sudden gush of clear fluid followed by vaginal bleeding. She is still feeling fetal movements. Her last normal menstrual period was on 28th of January 2020. What is the most likely diagnosis? What are the two common differential diagnoses? How will you confirm this diagnosis? How will you manage this patient? I will give you 2 seconds to think through this. You may pause the video if you want. And here comes the answer. So before I show you the answer, let me just give you a walk through this question. So you have this woman who's pregnant, and I presume whenever this question was set, and we shall use the current date, which is the date of this recording today, which I presume should be the 18th, if I'm not mistaken. So you have the 18th of October, 2021, and from January the 1st. So it means that the expected date of delivery should be somewhere around the 4th of November. So this woman should be roughly at around 38 weeks gestation. So she has passed term, and she has this gush of fluid that has come out from the vagina, meaning that the membranes have ruptured, and with rupture of membranes comes this vaginal bleeding. So I want you to keep this picture in your mind before I show you the answer. So most likely this woman has vasa previa. That's what's going to give you a characteristic feature of having this gush of blood as well as clear fluid. Whenever the membranes rupture, you should think vasa previa. The two other common differential diagnoses you should consider are placenta abruption, which of course will present with you painful bleeding, and then placenta previa will give you painless bleeding. Vasa previa will also give you painless bleeding. How will you confirm the diagnosis? Remember that you want to distinguish whether this blood is actually coming from the fetus or whether this blood is actually coming from the mother. You also want to determine the viability of the fetus, whether this fetus is alive. So to determine the viability of this fetus, and if there are any malformations that may be present or any other anomalies that may be present, you would want to do a pelvic ultrasound. Now, how exactly are you going to determine that this blood is coming from the fetus or this blood is coming from the mother? You may do what is known as a hemoglobin alkaline denaturation test, or for short, it's referred to as an APT test. So, and remember background, fetal red blood cells undergo some element of hypoxia inside the uterus because the uterus is a relatively hypoxic environment. So they are built in such a way that they resist this environment of hypoxia as compared to the maternal red blood cells, because fetal red blood cells also possess fetal hemoglobin in very high concentration as opposed to maternal red blood cells. So what you simply do is that you get 1 ml of this blood that is coming out from the vagina and add about 2 or 3 droplets of potassium hydroxide. Now, what potassium hydroxide is going to do is going to create a very stressful environment for these red blood cells. And if this blood remains pink or reddish, then it's most likely that it's fetal blood, and it confirms that you're having vasa previa. And if this blood turns brown, it's most likely that the bleeding is from the maternal side, which would, of course, point to other causes. How would you manage this patient? So because this patient is bleeding, you do your ABC. So you assess the airway that it's open, you assess that this patient is breathing, you give them oxygen, you also gain venous access, draw blood for investigation such as a full blood count, as well as a cross match because this patient may need a blood transfusion, and you also want to assess the level of their white blood cell count, their hemoglobin, and their platelets. You also want to start running intravenous IV fluids. You transfuse them if they're in shock, and of course, if the fetus is viable, you have to perform an emergency cesarean section because the fetus runs a risk of having what is known as fetal exsanguation, which is pretty much bleeding and draining all of the blood from the fetus, and it's very easy for the fetus to actually die. Moving on to the next question. Question 2. Para 7 mother, 49 years old, is admitted in the gynecological ward with a history of vaginal bleeding. The patient was treated for incomplete abortion 6 months ago. The patient is coughing blood. The beta HCG is about 100,000 international units. What is the most likely diagnosis? List 4 risk factors for this condition. What 4 investigations will be done to confirm the diagnosis and to treat the patient? Include rationale for choice of investigations in your answer. So I will give you 5 seconds to think through this and then give me your answer. Okay, now before I show you the answer, let me give you the rationale, or rather the background of this question. So you get this woman who has had 7 kids, okay, given birth about 7 times, or carried a pregnancy past the age of viability 7 times. And she's 49 years old, so it means she's quite old, almost reaching towards menopause. And she's coming with features of vaginal bleeding as well as coughing blood, which is referred to as hemoptysis. The beta HC is quite high, about 100,000 international units, something that you'd get in a pregnancy that's about 6 to 7 weeks. And of course, she's had a previous history of abortion about 6 months. So what you'd have to think, what condition would link a patient with hemoptysis, a high beta HCG, and coughing out blood? So if you were to think about coughing out blood, one thing that would ring in my mind would be, of course, endometriosis, because sometimes you can have these endometrial glands in the lung, and they may actually present to you with this cyclical type of hemoptysis, where this person coughs out blood, especially towards their periods or during their periods. But then that wouldn't really explain why the beta HCG will be that high, because it means that there is some beta HCG that's being produced somewhere. Maybe it could be a tumor of the lungs, who knows. But then also, if you're considering a tumor of the lungs, that also wouldn't explain why she's had the incomplete abortion and why she's had the vaginal bleeding. Perhaps maybe a metastasis to the vagina, but that would be highly unlikely. So here comes the answer. Most likely, this woman has a malignant gestational trophoblastic neoplasia. Remember that this malignant gestational trophoblastic neoplasia may arise in the uterus and may spread to 2 important regions. They may spread to the liver. If it spreads to the liver and the amount of beta HCG is not as elevated, then it's most likely has a good prognosis. But if it spreads to the brain and you have a markedly risen beta HCG level, then that carries a poor prognosis. So this is most likely a malignant gestational trophoblastic neoplasia, so a tumor of gestational trophoblastic tissue. And this is obviously going to be falling on FIGO stage 3. I shall give you the FIGO staging of this gestational trophoblastic neoplasias. And some risk factors include a previous history of a molar pregnancy, a multiparity, an increase in the maternal age, folate deficiency, race. For example, this woman, if she's Philippines or she's from the Taiwan, then she's at risk of developing these molar pregnancies. Now, the 4 investigations that would do to aid in your diagnosis and aid in the treatment, of course, you would do a chest x-ray that may show you the metastasis that you have towards the lungs from this gestational trophoblastic neoplasia. You, of course, want to do an abdominal or pelvic ultrasound to confirm if there's any presence of homogeneous intrauterine echoes with gestational sacs or without gestational sacs or without any fetal parts. You want to do a full blood count because this woman has a history of hemoptysis, so she may be anemic, and you also are interested in the level of the HB. You're also interested in the level of the platelets. You want to cross-match this person to determine their blood group as well as the rhesus factor, because if this woman is rhesus negative, then she requires anti-D immunoglobulins in order to prevent further occurrence of what is referred to as isoimmunization, rhesus isoimmunization, that may cause erythroblastosis fetalis in later pregnancies. The other investigations that you may do, of course, is a CT scan of the chest and the abdomen, which may also show you metastasis to the lungs. You may also do a CT of the head to rule out any metastasis to the brain. Here's the FIGO staging. So at stage 1, you have this gestational trophoblastic neoplasms that are confined to the uterus. In stage 2, they extend outside the uterus but are limited to the genital structures. So I mean the adnexa, the vagina, and the broad ligament. Then you have stage 3, which extends to the lungs with or without involvement of the genital tract. And then stage 4 is metastasis to other site. So this woman is at FIGO stage 3 of a a malignant gestational trophoblastic neoplasia. Remember, you have benign gestational trophoblastic neoplasias which do not tend to metastasize. That's where you talk about the complete mose and the incomplete mose, where you have either an empty egg being fertilized by a normal sperm, or an egg with normal amounts of DNA being fertilized by two different spermatozoa. Question 3. Cervical cancer is the most common gynecological cancer in Zambia. It can be prevented by screening women and treatment of precancerous lesions. A 50-year-old patient has been diagnosed with cervical cancer stage 2B. She has never screened for cervical cancer in the past. Part A. List 3 common methods of cervical cancer screening. B. Describe the pelvic examination findings in a patient with stage 2B cervical cancer. C. How is this stage of cervical cancer treated? D. List 4 common medical causes of death in cervical cancer patients. I will give you 5 seconds to think through this. So here comes the answer. So most likely the 3 tests you could do an HPV test. It's a PCR, a polymerase chain reaction type of test, which checks for HPV. You may also do a pap smear or a pap test where you actually get cells from the cervix. Now, a pap smear is actually one of the most successful screening techniques that has been developed over a while in medicine. There's no other test that is actually as effective with detection of a cancer as compared to a pap smear. You may also do visual inspection with acetic acid, and acetic acid is pretty much vinegar. Then describe the pelvic examination findings in a patient with stage 2B cervical cancer. So remember that this cancer is limited to the upper 2/3 of the vagina. So you may get a mass that is affecting the upper 2/3 of the vagina. It may ulcerate, and you may have these pieces of growth that may detach on the examining finger, and there may be some bleeding that may be associated with examination and of course involvement of the parametrial area. How is this stage of cervical cancer treated? Pretty much with chemotherapy and radiotherapy. I shall give you the different stages and the different treatments for each of the stages in the next slide. List 4 common medical causes of death in cervical cancer patients. So they die most commonly due to uremia, hemorrhage, or distant metastasis, often to the lungs, liver, and kidneys. They may also die because of generalized peritonitis. Here is a staging of cervical cancer, the FIGO staging. So you have stage 0, stage 1, stage 2, stage 3, and stage 4. So if you have stage 0, that's pretty much cervical intraneoplasia or CIN3. So this is where someone has an intraepithelial carcinoma or a carcinoma in situ. Because a carcinoma in situ and an invasive carcinoma, the difference is a carcinoma in situ has not yet breached the basement membrane, whilst an invasive carcinoma has breached the basement membrane. And remember that this carcinoma in situ is pretty much affecting the entire layer of the cervix but hasn't yet breached the basement membrane. Then you have a stage 1 where the cancer is clinically confined to the cervix, stage 2 where the cancer is affecting the upper 2/3 of the vagina or in the parametrium, but it hasn't spread as far as the pelvic walls. Then stage 3 where it's affecting the lower 1/3 of the vagina or the parametrial area and has spread to the lateral pelvic walls. Then stage 4 is obviously going beyond the true pelvis, and you may also have the mass going into the bladder as well as the rectum. So each of these stages may be divided into stage A and stage B. So you may have stage 1A, you may have stage 1B, you may have stage 2A, you may have stage 2B. Then you may have stage 3A and stage 3B, stage 4A and stage 4B. So take your time to actually ingest this and actually think through this in a very logical manner, because it is very easy to understand. And I shall leave this on your screen for a few seconds so that you can have a look at it. Pause the video if you may, and so that you have a good understanding of this. I want us to focus on the treatment by the stages. So anything from stage 0 to stage 1, we may actually treat them with surgical intervention. So you may perform laser or cryotherapy if it's in the endocervix. If it's part of the ectocervix, you may do what is known as a loop electrosurgical excision procedure, or in short, LEEP, or you may actually perform a cord knife cone biopsy. Then you may also perform a total abdominal hysterectomy. That's if the patient has completed childbearing. And you may do conization or cryotherapy if the patient actually wants to retain their uterus for future uses and for them to give birth again. Stage 1A and 2A, you would perform a radical hysterectomy with radiation. You may also perform para-aortic lymphadenectomy. You may perform pelvic lymphadenectomy. Then everything greater than that, so from stage 2B to stage 4B, pretty much chemotherapy and radiation plus or minus surgery. Question 4. A 16-year-old presents a week after a vaginal delivery with a complaint of leaking urine vaginally. She had a prolonged second stage and delivered by C-section after a failed vacuum. She also had an episiotomy done to facilitate the delivery. Question A. What is urinary incontinence? Part B. What is the most likely cause of the incontinence in this patient? Part C. How will you diagnose the diagnosis be confirmed clinically? Part D. List 4 common complications of this condition. Part E. How will this patient be managed? So I'll give you 2 seconds to think through this, but just remember that this is a woman that initially started with a vaginal delivery and then afterwards has now been complaining of urine passing through her vagina, and she had prolonged second stage of labor and then failed vacuum assisted delivery and had eventually been taken for C-section after even an episiotomy was done. So take your time, think through this question. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the like button, drop a comment to help me with the YouTube algorithm, as well as share the page. It will go a very, very long way. Thank you in advance, by the way. And here comes the answer. So most likely this woman has, so what is urinary retention? So this is involuntary urination or uncontrolled leakage of urine. So most likely this woman has a urogenital fistula, which may either be a vesical vaginal fistula, which is linking the bladder and the vagina, or it could be a uretero vaginal fistula, which is linking the ureter to the vagina. So why am I thinking this is a urogenital fistula? Because of this prolonged impaction of the presenting fetal part in the pelvis, it may cause tissue edema, it may lead to hypoxia, it may eventually result in necrosis and sloughing off that results from this prolonged pressure on the tissues of the vagina, the bladder base, and the urethra, and they can therefore stick to each other, they may erode into each other and result in this fistula. So how are we going to confirm this diagnosis clinically? You may perform what is known as a dye test. So this patient is going to ingest an oral dye, which is referred to as pyridium over here, or phenazopyridium. So you just refer to it as pyridium. And you're also going to be inserting indigo carmine or methylene blue into the bladder rather. Then you're going to be doing this via a urethral catheter. So you're inserting 2 dyes. One dye is taken orally, that's the pyridium. Another dye is inserted into the bladder, that's the methylene blue. Then you're going to also insert a tampon in the vagina. So remember that pyridium turns urine orange. So if it mixes with urine, it's going to make an orange color. And then methylene blue is going to turn the urine blue. So if it mixes with the urine, it will be turning blue. And remember, you have given the pyridium orally and you have given the methylene blue via the bladder. So if the tampon is going to be turning blue, okay, it means that there is methylene blue. The methylene blue that you have inserted into the bladder has leaked into the vagina. So most likely it is a vesical vaginal fistula. So it's coming from the bladder. If it turns orange, then you should suspect that there's a uretero vaginal fistula. It means that it's coming from the ureters to the vagina. And if it's turning both blue and orange at the same time, then it's most likely that they are both variants. Then list 4 common complications of this condition. So you may have recurrent vaginal infections, you may have recurrent urinary tract infections, you may have recurrent fistulas, you may have abscess formation, and of course complications may be related to the management, such as injury to the ureter, injury to the bowel, injury to the intestines, and additionally you may also have shortening of the vagina. How will you manage this patient? So obviously this requires surgical repair, which may be done via transabdominal or transvaginal techniques. Question 5, and indeed the last question, define the following terms. parity, attitude of the fetus, fetal station, precocious puberty, maternal death, secondary infertility, subtotal hysterectomy, neonate, term pregnancy, and last but not least, adenomyosis. So I will give you 5 seconds to think through this. You can start screaming at your screen now and telling yourself the answer. Don't worry, you're not crazy though. Anyways, here comes the answer. So parity is just simply the total number of pregnancies that have gone past the age of viability. In our case, our age of viability is 28 weeks, but some literature in some countries use a lower threshold of 20 weeks. Others even go up to 24 weeks. Then the attitude of the fetus is just simply the relation of the different parts of the fetus to one another. Universally, the universal attitude of the fetus is that of flexion, so most of the parts are flexed. Then fetal station is just simply the measurement of fetal descent in labor, and it's often measured using vaginal examination. Precocious puberty is just simply the development of signs of puberty if it's in girls before the age of 7 and if it's in boys before the age of 9. Maternal death is just simply a woman that's dying during pregnancy or within 90 days of birth. Secondary infertility is just simply the inability to conceive after 12 months of regular, unprotected sexual intercourse at frequent intervals after a previous pregnancy in the absence of any reproductive pathology. Then subtotal hysterectomy is simply just surgical removal of the uterus, but not the cervix. And then a neonate is the time period between birth and the first 28 days of life. Term pregnancy is any period of pregnancy between 37 to 40 weeks. Then adenomyosis is simply the presence of endometrial tissue deep within the myometrium of the uterus, of course. Thank you for taking your time to listen to this episode on MK's Exam Secrets. If you haven't yet subscribed, please hit the subscribe button. Hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment. We'll leave no one behind.